everybody. I'm Muriel Heiberger. I'm very happy and excited to welcome you to this program, COVID-19 and Us. When we first started thinking about this program back in May, the impetus for it was the fact that Massachusetts was moving slowly but surely into new phases of opening up. We weren't sure if people had already had enough of COVID-19, but it turns out now with this tremendous surge in cases all around the country, and especially in the South and Southwest and in California, I think it's a very timely program. So we're very happy to welcome you all. We're going to begin with Dr. Rebecca Weinberg, who I'm going to introduce in a moment. And Rebecca has a fabulous presentation for us. So after Rebecca's presentation, we'll gather in small groups, and we'll have facilitators in each of the groups and hopefully a very lively conversation. And then we'll bring everybody back for a very brief closing. I just want to say one word about the presentation with Rebecca, how we're going to do it. I'm going to pose a question, and Rebecca has a lot to say and a lot of information to share, so I think we'll all learn a lot, and it's going to be quite an exciting evening. So without further ado, I want to say a few words about Rebecca. Rebecca is a hospitalist and associate physician at Brigham and Women's Hospital. She's an assistant professor at Harvard Medical School in the Department of Global Health and Social Medicine, and recently appeared in the Netflix documentary, Coronavirus Explained. And last but not least at all, she's a member of TVZ with her family. So I think, Rebecca, we're ready to begin.
Terrific. Well, first thing, thank you, Rob Farid, and thank you, Muriel, for inviting me to join this stellar group. I am incredibly proud to be a TVZ member. I realize this is my 16th year of membership, being a TVZ member, and I joined a few days after I just gotten married and across the country, and it's just been an incredible home for me. So I'm so thrilled to join you all. If I haven't met you in person, looking forward to virtually meeting you and then physically meeting you quite soon. So Muriel did an incredible job of setting this up, because she sent me an incredible group of questions you had submitted to Muriel, which is impossible to summarize in one evening. And I know the TVZ community that we need data, we need evidence, we need to interchange and discuss it. So what I'm hoping to do is give you a few highlights, a few tools, and that this will be like a discussion of the Torah. You know, there's debate here and ongoing analysis that will need to go back to this evidence that I'm sharing this evening. So I hope you can see my slides here. So I just want to give us a bit of historical backdrop that this is all recent history. This is a novel virus. We did not know about this virus, though it was part of the coronavirus family. And it's really December 31st when our colleagues in China alerted the World Health Organization to say there was a cluster of unusual cases of pneumonia. And then the virus was actually identified January 7th. So considering the speed of science and discovery, the fact that literally less than 100 days later, we had understood the structure of this virus is an incredible accomplishment. And there's much more to learn ahead. But I just want to spend a few minutes giving us a sense of the nature of how this pandemic unfolded, and then the disparities that have occurred in the second wave, in this phase that we're in today. So one thing I want to mention, and I apologize, the slide is messy, but I want to remind us when we first understood the structure of this virus, that's the orange part of the slide, we thought it was quite similar to SARS. And SARS is one of the coronaviruses. And so we were thinking that it was transmitting this virus similar to SARS. What actually happened on February 22nd is that there was one mutation of this virus, which means that it changed slightly and it actually became more infectious. This is likely why asymptomatic carriers are transmitting the virus. It's not exactly clear, but this is what we're suspecting. So this figure on the bottom where I'm showing you where someone's coughing in orange, then the mutation happens and they're coughing in blue, you can see there's higher viral loads in the person who's coughing in blue. This doesn't mean that it's more severe. This has an effect, more cases of pneumonia, but acknowledging that the understanding of the transmission changed, likely as the virus changed on the state in February 22nd. The second piece that's evolved that I think we've all been following carefully is while the pandemic began in China, it has now not only evolved globally, but the proportion of cases that we're seeing today are in the Americas. And what we think about the burden of disease that Brazil is facing, the United States is facing, is quite different than in this first phase of the disease when we are tracking cases in China and elsewhere. Excuse me. I also just wanted to mention that the pandemic has splintered not just by geography, but also by demographics. It's almost in a sense become separate epidemics due to your demographics. That means, for example, by your ethnic affiliation, by your race affiliation, and we're trying to understand why that is. And this graph from the Los Angeles Times reminds us that in 3 states in the United States, we're seeing a much more significant hazard ratio of being Black versus white. And now we're trying to unpack why is that? And there's several pieces to this puzzle. It's likely related to chronic disparities in access to capital, chronic disparities in access to healthcare. And each of these exposures are leading to furthering this disparities. So your risk at work, if you're required to go to a workspace that may not be following practices in social distancing, your risk of needing to use public transport to get to work, your risk of sharing the lived space, your comorbid health conditions, as well as issues regarding your access to testing and healthcare, the structures of healthcare delivery, including the racist practices within our systems, and chronic stress and the relationship between chronic stress and your ability to combat COVID-19 pneumonia. So I apologize that this seems somewhat dismal, but I want to remind us that the actual pandemic looks different than it did in January and February. The issues are different because of where it's spread and what demographics are more affected by this novel virus. So I will stop there. Should I continue on, Muriel, or?
Should we? I'm going to move on. I want to thank you so much for giving us this big global picture, Rebecca, and also for giving us a really clear sense of the disparities and the different ways that this is affecting people who are suffering with this. But I'd like to turn, if it's going to work with the slides, to Massachusetts. And to ask you if you can talk a little bit about, to orient us about where Massachusetts is at in this picture now.
Sure, please do. I'll just spend 30 seconds on the most common questions that we are still asked about coronavirus. And you all probably know this. This is like biblical text. You've heard this from many forums, but just to get our heads wrapped around that still we know that the most common symptoms are fever, cough, and shortness of breath. And we also know that we need to be tested by a PCR testing. If anyone's been tested, we can talk about that later on. And just want to also acknowledge that the data is quite clear that the average time from exposure to your symptoms is still about 5 days, and that 62% of transmission occurs prior to the onset of symptoms. So that means you can transmit prior to the onset of symptoms. That's when most of the transmission is happening, and that's in every state across the nation. I'll skip this. I also just wanted, before we get into Massachusetts, or give a highlight to why Massachusetts has been so successful, is because of the practice of the majority of the public, children, adults, elders, practicing this inner teal circle. So this is what we know of how to stop transmission, is to wear a mask, is to actually practice distance if you're able to, and your own personal hygiene, so wiping down surfaces. Those 3 practices have actually led to the decline in the number of new cases and the severity of cases that we're seeing within the state of Massachusetts. Then these other structural concentric circles, we have very robust systems in Boston in particular to ensure how we're thinking about screening and triage, how we're laying out indoor spaces and actually how we're thinking about scheduling of healthcare. I just wanted to acknowledge that there's system leaders in each of these elements, and just give Massachusetts quite a high rating for this inner teal circle. And Muriel, to your question, kind of how we are doing today, this is the map of case counts with the existing policies. So this is stage 1 and 2 for April and May. And here we are on this light blue line of today. The dotted dash is modeling. So what we think the cases, how the cases may arise. But the reason why I'm giving us a high score is because this is what the curve would have looked like if we had not practiced those policies. So the green part of your screen, if you see to the right, if we had not practiced social distancing, if we had not worn masks, you can see where we would have been regarding the number of cases. And the line where we were right before here is now looks quite low, right? This is actually where we are. So we've done an excellent job as a state in flattening the curve. And this tool, if you're interested in looking more, you can actually look at every state in the nation and compare, is it the practices that it's practiced and the effect on flattening the curve. And just a few more visuals. Here's the cases from Tuesday. The number of cases. I'm actually going to recommend that you do not follow the cases day by day, because the cases will change. And so I've had this conversation with several TBZ members. My recommendation is if the cases are going down for 3 weeks in a row, that's a solid marker that we're going in the right direction. But do not every day go to a website and look at the cases. It does not matter if there's 5 or 10 more cases or 50 or 10 more, it's the trend line over 21 days. That's quite important. The second piece of Massachusetts is we have really, our health systems are ready. We have the beds ready. We have the personnel. We have the PPE. We have the ventilators. There is sufficient staff, stuff, and personnel to care for those who are COVID positive. And we also have the capabilities of referring between hospitals, which is a lot of work that I do. And there's just excellent communication with Cape Cod Hospital, Nantucket Hospital, as well as Western Massachusetts, to ensure we're distributing the beds and services as needed. And this is just another way to look at the data over time. And I just want to remind everyone, the trend is all going down. So the number of patients who are hospitalized with COVID-19, the hospitals needing surge capacity is going down, and COVID deaths are going down. And also, many folks are asking, where do I get a test? So this is a website, and I have all the links to these websites if you're interested at the end of the deck here, where you can find a testing site close to you. And it will show you the phone number, what type of insurance it takes, how to contact so that you don't have to walk into the testing site. So you can go deep into this map and find a testing site that's available for you. This is getting updated daily. So tremendous testing capacity within the state. We actually have extra tests at this point that are sitting at the Broad Institute that we're sending to other states at this time. So we have surplus capacity. So I think that was the part of the deck, Muriel, to help answer.
Okay, I'm gonna sort of switch gears a little and just make the observation from what I know to be true of the aging and community group that I'm most familiar with, and that is that really one of the toughest things for many of us has been the social distancing issue. I think now, because the state is beginning to open up, a lot of people are struggling with all kinds of decisions about what can I do? Is there any possibility of resuming some of the activities from my life before COVID? What is the risk involved? How can I really take best care of myself? So we're really looking to you, Rebecca, for some guidance. One on how to keep ourselves safe, going through the different activities I sent you, and letting us know, sort of giving us a risk assessment so we have a sense of how to really guide ourselves in making these decisions.
Well, thank you, Muriel. This is a very complex question that I'm going to offer some general guidance and a tool for our community, and acknowledge that everyone that's on the call tonight and everyone within the TBZ community has different risk factors. So we're living with in different family units, we have different exposures, and we also have different risk tolerance. We understand risk differently. And we also want to balance our physical health with our emotional health. And actually being in proximity to others for most of us is important. And there's actually studies that when we're with other people, there's actually energy from them. So how do we practice it safely? Muriel, is a great question. The other thing that I'll just mention, I have parents and a grandmother, and I understand how hard this is to practice this type of distance to those you want to be in proximity to. Also acknowledge that the risk is significant. So people have asked kind of on a family level, I'm not flying to see a family member. I'm not recommending that my parents or my grandmother get on an airplane at this time due to the complexities of moving from one state to another that has a different level of prevalence of the disease of transmission. So here is what I have been using and pleased to share with others, and we'll share this with you to think about what is a low risk activity, a moderate risk activity, and a high risk activity. So there's been several sets of questions regarding, excuse me, hugging or shaking hands when greeting a friend. That's rated as a 7 on the scale. So we're all finding other ways to greet each other. Another one I think that's quite common is sitting in a doctor's waiting room has been rated as a 4. So that's because the actual architecture, the interior design within many waiting rooms has been altered so that you can sit 6 feet from each other. And then there's, I think, other things that people have asked many times with TB, the thing about TBC, opening the mail is a low risk activity. So we know the virus does not live for long periods of time on a piece of paper. And so there should be less concern, though we had a significant amount of concern in the beginning. I would say there's less concern, obviously, with something like opening the mail. So I will share this with you if that's helpful to put up on your fridge. Think about if this is a helpful guide.
Yes, I'm imagining people desperately scribbling down these things.
Oh, no need. I will share
no
all
need,
of this.
People. It will be in the chat, and you can access it. Okay.
I'll share this the whole deck with everyone, so no need to write anything down. And I just want to give you another sample of something that I've been using with patients. It's something called 19andMe. So it's an individual COVID-19 risk score. So you can go to the links on the bottom of the slide here, and I'll share all these links with you. You go into this tool and you actually put in your zip code, your age, your sex, your pre-existing conditions, and your behavior. So you can discuss, do I live with other folks? Am I performing hand hygiene? Am I wearing personal protective equipment? Am I wearing a mask? And it actually calculates your individual risk score based on where you're living. Just to remember, the experience of living in Boston with a low case rate is quite different than our friends and family who are living in Florida or Arizona today. And what it looks like is it gives you a score. It gives you some advice based on the active cases. And I just wanted to share this part of the guidance. So, and I apologize if the text might be hard to read. It's in general, washing your hands lowers people's risk of being exposed to COVID-19 by 55%. That's actually very effective for NT intervention. And good to know wearing your PPE, so wearing your mask per COVID guidelines, also lowers your risk of being exposed to COVID-19 by 68%. That's actually excellent. There aren't too many interventions that we have in all of medicine that we can tell you at a population level reduces your risk. So it just reinforces your practice that you're already practicing today. That lowering your risk by wearing a mask, for example, and having good hand hygiene will decrease your risk of exposure.
Can I throw out something that came to me?
Please.
Somebody mentioned in their question that they had noticed a lot of people wearing shields. And they were wondering if a shield without a mask is effective, because this person has difficulty, their glasses get all clouded. Is it effective, or is it more effective to wear a mask and a shield? What are your thoughts?
Yes, it's a great question. I don't have data to share with you, Muriel. So this is, I'm sharing with you kind of judgment and experience. So as a healthcare provider, because I'm in the inpatient setting, I wear eye covering and a mask required. And so some people then have chosen to wear a shield and the mask, which is quite similar. So we understand there's a sense of if you're not used to wearing a mask and getting adapted to a mask, that's why the shield has been adopted by some. The mask, needs to be worn properly. So also we are acknowledging people wearing the mask underneath their nose doesn't do much good, unfortunately, or in their hand or on their neck. So some people think actually by wearing the shield, I'm not forgetting to wear my mask properly. But the data on transmission has always been with the surgical mask, not with the shield. So we don't have sufficient data, but it makes sense that it's creating a barrier. It just may not be as sufficient a barrier as a mask.
Great answer. Thank you very much, Rebecca.
Yeah.
So
Excellent.
now I'm going to turn to the question that so many people are wondering about. Vaccines. Can you share with us a little bit about what's happening in the vaccine development world? What are the phases of vaccine development? Who and where are the companies who are doing this? And I'm not going to ask you for your best guess on when a vaccine might be available, but just for us to have a sense of what the process is for getting to that point.
Yes, no, thank you, Muriel. And I know this is a complicated question because we have to look back historically when we've had a novel antigen, something that we do not know that's infecting the population. How long does it take science to create a vaccine to elicit an immune response? That means actually create an antibody so that if you end up having that virus, for example, you can host a response and you don't get sick. So what I just wanted to show you here, if you look at this pathway, this is the vaccine development pathway. If you add this up, it usually takes 10 to 12 years to go through this cycle. 10 to 12 years to go from discovery, understanding the target, preclinical, phase 1, phase 2, phase 3. So the speed of progress where we are today, the fact that we have several candidates that are in phase 1 and even 1 or 2 in phase 2 is a tremendous moment regarding the speed of the science. That does not mean we're not going to face bottlenecks as we're waiting for phase 2 study and phase 3 studies to come out. So I do want to temper some of the language that's being used regarding something called Operation Warp Speed out of the White House. That's getting capital to the companies to go through this phase 1, the safety of the vaccine, phase 2, safety and immunogenicity, and phase 3, safety, efficacy, and regulatory approval. And the quality of the data that's needed for each of these phases remains the same for any vaccine. But what's been, in a sense, accelerated, or if you think of the warp speed, has been getting capital, literally getting the money to the companies to begin the testing process, not the speed, or we're not shortcutting any of the quality of the science to prove, is this vaccine safe? And then obviously, is it effective? And I say that with concern because I do hear many people saying the vaccine is coming and setting up these dates. That is almost, I don't know any scientist who's saying I am confident a vaccine will be ready in 2021. What people are saying is that they'll get through a phase of the trial, of the clinical trial. But you can imagine the manufacturing delays, the procurement delays, the distribution delays that will come of it. So just a few concerns about this. I wrote this piece with several colleagues in April, reminding us that in order to end the pandemic, we would need to think about how we're distributing the vaccine. That if we began with this principle that we are a global nation, that we're in solidarity with others, we'll be able to combat the virus with the science of the vaccine. Unfortunately, what's happened, and I think many of you are following this, is that we've had very much a nationalistic front. Here, people are talking about preserving the supply of the vaccine for certain nations. And that will not help us end the pandemic. We'll have reservoirs of disease in many spots of the world that will come and reinfect the global population. And so to counter that, there's a multilateral effort called ACT, A-C-T, that the multilaterals are supporting, 150 countries are supporting, to say we will actually allocate the vaccine by country, not by who is the highest bidder. We won't let the capital markets run the allocation. Unfortunately, the United States is not participating in this multilateral. And so we're all concerned about this and talking about it and think about how do we influence this front. And so there's work ahead to do on this effort. The second question that I do get quite frequently, and I think it was a mention, Muriel had an excellent question for me earlier this week, is it's exciting to see the notes and the early data that came out of Moderna. So this is actually a company based in Massachusetts. They created an mRNA vaccine. And I just wanted to share that this is a very incomplete data set that was released in the New England Journal of Medicine on Monday. It's really, the data set is from 15 individuals, 15, who received a certain dose of the vaccine, 100 milligrams, which is going to be a much higher dose than we likely distribute. And the data shows that it's eliciting an antibody response. So that means they're giving you the vaccine and you're hosting some antibodies, but we do not know how long those antibodies last. And certain populations, especially our over 65 and over 75 population, we're concerned that you may begin developing antibodies and the antibodies may not last. So it's likely you're going to need 2 doses of any vaccine. So just noting that, and pleased to share if people want to get into the actual data, and I have a 100-slide deck just on this data set, just to remind us to temper the enthusiasm about this. This is very early data. There's a tremendous potential, but this does not let us say that there's going to be a vaccine within the calendar year. What it says is that we understand some of the science to host a response based on this novel virus, and there's promising results that we'll be able to host that response in 15 individuals.
I know you have a beautiful slide that shows vaccine development around the world. Can you share a little of that with us?
Absolutely, yeah. So we're tracking, there's now 195 vaccine candidates. So that means 195 companies have registered a vaccine candidate that they would like to begin a clinical trial. And why we're tracking this is because some of the contenders are not from typical labs that we know of well, but they either have experience with other coronaviruses, they have new platforms, and there's a tremendous interest in understanding the diverse candidates that are coming into this pool. And also so that many of these institutions that normally have never run a clinical trial can access and practice safe and effective clinical trials so that data can be interpreted by the globe. So that's a piece of work that we're working on to ensure that the clinical trials are structured well and that the data becomes public. I bring this up kind of as a final point because this is an unbelievable effort of scientists collaborating with each other. People are sharing their study designs, they're sharing how they're running the trials, they're sharing early data to help each other so that we have a robust portfolio of vaccine candidates. And I guess my only projection here is that I suspect we'll have multiple vaccine candidates that are safe and effective. They're going to be effective in different populations. So someone who's 20 years old may get a different vaccine than someone who's 80 years old. Some folks may need 1 dose of the vaccine, some may need 2. The vaccine may end up being embedded in your influenza vaccine. We don't know quite yet. But acknowledging that with this speed of science, there's tremendous potential and we need to harness the investment, the excitement, the interest, but there's several implementation bottlenecks to ensure that the general population has access to doses of the vaccine. So work ahead for many.
And I have one last question for you, Rebecca.
Yeah.
And I'm asking it because I think that many of the people in our wise aging and our aging in community cohort could be in this situation. Could you give a suggestion? I don't want to say advice, but a suggestion to someone who's 65 or over and has an underlying medical condition that puts them more at risk for severe illness. Can you give a suggestion to that person about how to approach this sort of reopening phase in a way that will be least dangerous?
Mm-hmm. That is a great question. I mean, the early data that I looked at with several colleagues in March is the role of wearing a mask. And that has been very clear, that the mask protects you and protects your neighbor. And consistently wearing a mask when you're with those you may not have been around. There's a question about when a repair person comes into your apartment or home for you to have your mask on. That is probably the singular protective piece of equipment that you can practice consistently. And I would recommend that for any age group at this point. So when you're inside a building with someone else or going into an indoor space, to ensure that you have a mask on.
And Rebecca, I wish that we could clone you and have your voice spread this message all over the country, but it seems like it's catching on a bit more after these last disastrous few weeks. Okay, I know that I asked you how long we could plan on having you, and I think we've a little bit exceeded that time. I can't thank you enough for this absolutely not only beautiful, but incredibly informative presentation. We are so lucky to have you as our resident expert, and I really can't thank you enough for taking your time to share with us. I want to reiterate that many of the tools that were very interesting that Rebecca used that would help people assess risk in given situations will be in the chat, and you can get access to them. I deeply and profoundly appreciate your willingness to share your amazing expertise with us, Rebecca. It's been a very terrific time. We're going to move into small groups, and Penny, one of the people on our Aging and Community Planning Committee, will tell you a little more about what we're going to do. But I just want to say to our community one thing. I think probably COVID is going to be the most unusual challenge we may face in our lifetimes. I hope that we can tap into our wisdom and our resilience and the knowledge that we've developed over our lifetime of experiences to see us through this. And we hope that Aging in Community can be a resource for people as we go through the next several months, many more months, we don't know. So that's my last word. And I'm going to turn it over to Penny Roberts, who's going to tell us about the small groups that we're going to go into very shortly. Thank you again, Rebecca. That was spectacular.
My pleasure. Muriel, wonderful to work with you.
Wonderful to work with you. Okay, Penny, you're on. Take it on. Take it on.
Hello, everyone. I also very much want to thank Rebecca. It was really fascinating, and it'd be very neat to have some of those fun graphs and things to share with my nearest and dearest. So now we're going to break out into small groups to have an opportunity to discuss things. We have some proposed questions for people to focus on, and there will be a facilitator in each group, or at least that's our hope. And I put the questions in the chat so that everyone can see them. Does everyone know how to, I assume everyone will know how to open up the chat and to look at them. And then after we'll have a half hour or so to chat, then we'll come back to the whole group and we'll have some final words from Maxine.
So can I just jump in for a moment? Because two things. One, Penny, can you please repost them in the chat, because they came in early and not everyone was here when they came through. So if you put them in now.
Oh, that's how that works. Okay, can I? Okay, let me see. I will
try. Sure, take a moment. And Larry Krause, who's the head of our reentry committee, would love to say a word about TBZ and our stance on COVID and reentry.
Let's see.
If I can.
We're against COVID. That's our stance.
It's
I
not
want
too
to just
hard.
say, Muriel, you're awesome. Thank you for your emceeing, really great. Rebecca, you're awesome. And I wanted to let people know that last week or the week
Wow.
before,
I don't want to.
we had a meeting with Rebecca and other resident experts, Asaf Baton and Catherine Gergen Barnett, to get some of this great data and some of the scientific knowledge so it could inform what our options are for high holidays. As Ralph Claudia says, high holidays are going to happen for sure. It's just a question as to how we're going to join together and how we're going to be together to pray and to celebrate and to make those holidays as special as they always are. So we are relying on as we've said throughout, we're relying on our experts. We're relying on the knowledge we have in-house. We're going out-house when we need more information. And there's nothing to tell you now except that we're in process, more to come. Wanted to let you know.
And I'd like to add a word. I want to say on behalf of many people who have said this and shared this with me, that the very thoughtful process that TVZ is using to consider next steps and steps after next steps is really awesome. So there are no words to say how much we appreciate and feel safe and comfortable knowing that you're really working very hard on this, and we appreciate. I wanted to invite you, Sarah, to be on this call to say a few words, but I was told you were on vacation.
No,
So
that's
I didn't want to
Next week.
interfere.
that starts
Next week.
Saturday, but I'll let my better half say that, he said what we needed.
Good.
I
Thank
think
you.
everyone needed to hear.
Okay, Penny,
No.
did you get that in the chat? Because you have to unmute yourself, Penny.
Okay, I was having a problem unmuting myself. I did enter it in the chat. You don't see them now? It says from me to everyone.
Okay. Okay, so I think we're ready, Ralph Tufera, to go off into small groups. And I should say we have wonderful facilitators to help the conversation.